Okay then, so it's 10 o'clock. Good morning, everybody, and thank you for joining us. I'm Dr. Lizzie Toberty, and I'm a GP with the Doctors Association UK. I'm based up in Newcastle, and I'm in the surgery at the moment. And I just want to say, first of all, thank you so much for coming. It is not lost on us that you guys are really busy and have precious time, and it means a lot to us that you have chosen to spend an hour of it listening to some of the issues that are present at the moment within general practice. So why can't I see my GP? The Great British Paradox. Next slide, please. And I think, the irony isn't lost on us. Why can't I see my GP? Well, you have 4 GPs who are working now actively within the NHS who are here to speak to you this morning. And we're going to, you can see them on the panel above, and I think they're going to turn their cameras off, and we're going to introduce ourselves in turn as our sections come up. Just to mention, this is being recorded. And also, if you would like to ask any questions, please do. We're going to answer questions at the end, but please feel free to comment and chat in the sidebar. Next slide. So first of all, we've got a video of a long-term friend of Doctors Association who you might recognise, Dr. Amir Khan, and he recorded this for us on Monday, just talking a little bit about his time in general practice. I don't think the sound's working.
Most people when they're feeling at their most vulnerable. Today alone, I've seen patients who have been worried about potential cancer symptoms, someone who was wanting to end their life through suicide, someone with complications of pregnancy, someone who had dementia and wasn't coping at home, a child with a rash, and I've done a home visit on a housebound patient who was unwell. And the list goes on. Now, it is this breadth of knowledge and experience that we GPs have that makes this job vital for the future of the NHS. But we are struggling. Our budgets have been cut and we are expected to do more with less. Not just more clinical work, but social care and the impact of cost of living crisis is all seeping into the work that we do and the health of our patients every single day. We want the next government, whoever that might be, to recognise the importance of the work that we GPs do in communities like the one I serve here in Bradford. We are the very foundations of the NHS, managing people at home when it's best and gatekeeping access to hospital care for those who do need it. Value us and invest in us. A well-functioning and healthy primary care service will only have positive repercussions on both the NHS and social care. Hi, I'm Dr.
Next slide, please. So what we really want you to go away from today is, yes, there are problems within general practice, but those problems are not insurmountable. Those problems, with the right understanding of what's caused them, the right understanding of the evidence, and the right understanding of what patient wants, along with political will, these problems can be solved and we can improve access to general practice. So we're going to talk you through today the joys, the challenges, the data, and the solutions to the issues in general practice, and why is it that people can't see their GPs. Next slide. And I always put these type of slides at the end, but I'm going to put it in at the beginning today. Please keep in contact with us. We love talking about all things general practice, and if there is something that we've said today that has sparked your interest or hasn't quite made sense, please do get back in contact with us afterwards, and we are more than happy to talk about it. But the other thing that's becoming abundantly clear to me is that you have to be in general practice to understand it. And if there's anything, again, that's puzzling, perhaps consider coming and sitting in with us. I am more than happy for anybody to come and sit in with me. And if you're not in my area of the country, I am sure we can connect you with a GP closer to you if you want to understand what your local issues are and visit a practice closer to home. So please know that there is an open-ended invitation to our briefing today. Next slide, please. So what's the paradox? Why have we called it the Great British Paradox? Well, we're really perplexed by some things that are going on in general practice at the moment. It doesn't quite make sense. So we know that patients, and we're patients ourselves sometimes, and the electorate really value general practice. There's a lot of debate, a lot of noise around it. And we know that people really value being able to see their GP. But yet the portion of funding in the NHS that's spent on general practice has actually fallen. And in real terms, over the last 9 years, we've seen a 20% reduction. The other issue that we are seeing that has been highlighted just this morning by the RCGP, our college, in the Times, is that there is now a growing issue with GP unemployment and underemployment. At the start of August, we're going to have 4,000 new GPs qualify at a cost to the taxpayer of £200,000 each. And there are not enough jobs for them. And in fact, in some areas of the Northwest, trainees are even being told to relocate because there are no jobs. But the paradox gets even more puzzling when you look at what's going on with the money. So actually, there is money in the system and there is money being passed back to the Treasury, but it's not allowed to be spent on doctors. So what is going on here, and why is it becoming so difficult to see a GP when there's money, there are doctors, but yet we can't employ them? And the final paradox is really, why is it that doing this job, a job that involves talking to people holistically about well-being, why is it that sometimes it can make GPs themselves unwell? And we're not alone in the NHS. There's lots and lots of staff that are suffering the same. Next slide, please. And so the title of this presentation is based on a book by Dr. Ellen Welsh, who you're going to hear from shortly. Why Can't I See My GP? And that is a book that we sent to every MP in the country back in March. And we're hoping really to highlight that again to you today. So to start us off, I just want us to think about what was your last experience of the GP? Because I think that colours our opinions about GPs and about what's going on. So maybe it was an appointment for yourself or somebody else in your family. Maybe it was with a doctor, maybe it wasn't. Or maybe you got it on the day, or maybe you'd waited weeks. And it's just important to hold that in your mind when we're talking about the issues within general practice, because there's a lot going on. Next slide, please. And one of our colleagues designed this graphic, and I think it really demonstrates things really well. There's lots of talk about face-to-face appointments, and face-to-face appointments are great. I love seeing patients face-to-face, but it's only part of what we do. There's an awful lot going on under the surface around paperwork, admin, pharmacy, safeguarding, meetings, just to name a few things. And that's why we're encouraging you to visit your local practices, because actually there's a lot going on. Next slide, please. And I just need to say a word about this report, the Fuller Stocktake report from NHS England in 2022. And if you haven't read it, it's really worth having a read, because this is dictating the current course of action and a lot of the narrative around general practice. Now, in this report, Dr. Claire Fuller makes the presumption that continuity of care is only needed for some, not all of our patients. And that a lot of the problems around access are because people can't access care when they're acutely unwell. And because of that, there's a current narrative that we need acute care hubs, and then we need GPs doing chronic care within GP practices. So if you're unwell in the future, you might be sent to an alternative site, not sure how far that will be from your home, and you might see a doctor. You more than likely will not see a doctor at those sites. They will be allied healthcare professionals. Now, we just at the Doctors Association want to challenge that narrative today. We think continuity really matters. We think patients want to be seen in their practices, and we believe that that is not out of our reach at the moment. Next slide, please. So again, one of the things in the backdrop, one of the narratives, is that actually being a GP perhaps isn't that hard. Perhaps anybody can do it. Perhaps we're overtrained. And obviously, we really disagree with that. We feel very strongly that's not the case. And if I could just explain a little of that. So, for instance, it makes the presumption if you have symptom A, you've therefore got disease process B, and therefore you need treatment C. So an example of that is it hurts you to have a wee, and so therefore you must have a UTI, and therefore you need antibiotics. Next slide, please. But that simply is not the case, okay? So when we're seeing people, we're thinking holistically around what is going on. So sometimes it might be actually that the problem is an irritable bladder, or maybe that it's a different type of infection, or particularly where I am in Newcastle, we've got a high student population, and I know there's a lot of ketamine use, and I know that that can cause problems with painful passing of urination. But also, who's picking up the people with bladder cancer? If we see somebody different every time, is anybody going to pick up that person who is representing again and again with the same symptoms? That's the worry. And I think the real concern is that we're turning our healthcare into a transaction, that we're turning it into an Amazon Prime Day type service. Now, I know when I am ill and I am anxious and I am stressed, I want to be seen as a person, not an Amazon Day package. And I think that's really important to remember. That's what our GPs want, our patients want, sorry. Next slide, please. And so I just want to very quickly talk to you about what it is that a GP adds to the system. And increasingly, I'm feeling a need to justify my existence, to justify my training, and to justify why it's important that myself and my colleagues have the skills that we do. And so in terms of the model that we are using within general practice, we are trained in what we call the biopsychosocial model. So only about 30 to 50% of symptoms that patients present with will have a physical underlying cause. And a large proportion will actually have a psychological or social cause behind it. So by that, I am thinking about if you're stressed and you develop some headaches, or you develop irritable bowel syndrome, and that's all part of. There's a lot of carer stress, a lot of people looking after their relatives with dementia. I'm just aware my computer's saying to me unstable connection, and I am on NHS IT, so please bear with me, and if there's anything you need me to repeat, let me know in the chat. Next slide, please. And the second aspect is the continuity of care. So part of what we're doing is we know that it is studied and evidence that if you see the same GP over time, that you will be less likely to die, you'll be less likely to be admitted to hospital, you will be less likely to be prescribed drugs, and you'll have improved patient satisfaction. Now, if we had a drug that did all of those things, we'd be putting it in the water. And so I asked the question, why are we developing policy that actively fragments patient care when we know what is good for them, but it's also what is good for the wider system? And it's also the thing that makes my job joyful, is seeing the same patients again and again, and it helps me to be more efficient in my care too. Next slide, please. And so finally, the final kind of part of our care is that we can deal with risk. So when I'm seeing somebody and they're really unwell, in some ways it's easier because I know they're really unwell. I know they need to go to hospital. And a lot of the time, people are quite well, and I feel perfectly comfortable to reassure them and send them on their way. However, I think where we spend a lot of our time is in this amber zone, where people aren't completely well, but they're not completely unwell. And we can't send everybody into A&E, and we can't send everybody for a CT scan immediately. So the fact that we have a large, broad knowledge base allows us to understand the meaning of the guidelines we're dealing with. And that allows us to hold a lot of risk within general practice. And that allows the system to function. And it was once described to me as a shock absorber. And I thought to myself, I should put a picture in. I thought, I don't know what a shock absorber actually looks like. And I think that's because we don't really see it, we don't feel it. And so we start to think maybe we don't need it. And it just goes back to what Dr. Amir Khan was saying at the beginning, that we are the bedrock, we are the risk absorbers of the NHS. And if you lose GPs and you employ staff who are not as able to take those risks with undifferentiated illness, it will actually pile the pressure and the cost onto secondary care. It is in all our interests. It makes sense, and it is evidence-based that us GPs are here and dealing daily with our patients. Next slide. And so to put this together, this really is the joy of being a GP. This is why I continue to do this job, is because I have the puzzle of why this patient is here. I have that ongoing continuity of care and that ongoing relationship. And that enables me to take the risk and hold the risk here as much as possible within the community. So I hope that made sense. And I'm going to pass you over now to Dr. Sarah Jacks.
Good morning. I'm a GP down in East Sussex, and I'm going to give you a feel of what the job is, how the job is becoming unsustainable and what effect this is having on the workforce. I'm afraid that this comes with a trigger warning, as I'm going to be talking about suicide. I'm going to tell you a little bit about my story now. I started working as a full-time GP back in 2007. And for most of my career, I've worked as a GP partner. I love my job and I was completely dedicated to it. But even 10 years ago, I was working 12 to 14-hour days. On average, I would have about 35 to 40 patient contacts, but I have had days where I've had 100 patient contacts. And in fact, the BMA recommends that the safest number of appointments offered each day is 25. On top of my appointments, I would have about 60 to 70 clinic letters to action, 60 results to interpret, 70 tasks to complete and referrals to write, and hundreds of prescriptions to check and sign every day. On top of my 8 clinical sessions, I also was the practice lead for COVID, clinical governance, safeguarding, and HR. Then there was all the work that you saw depicted in that iceberg infographic that also needed to be covered. To do that, that meant that I had to spend a lot of my days off completing the admin. I would also have to go in on weekends and sometimes give up my annual leave to make sure all the work got done. This meant I rarely had lunch breaks or even had time to go to the loo. And unfortunately, I'd been working at this intensity for many years. So by August 2022, I had become exhausted and overwhelmed and really quite demoralized. I was finding it really difficult to accept that I was no longer delivering a gold standard service. And so I suddenly snapped and actually walked out of the middle of an on-call clinic. And I drove to the seafront where I contemplated ending my own life. By the time of my breakdown, I was working 50 to 60 hours a week, and I had 3,000 patients registered under my care. Next slide, please. Unfortunately, I'm not the only one having to bear the brunt of the pressure of the workload in the NHS. Experiencing an epidemic of suicides and breakdowns amongst medics, with one doctor dying by suicide every 3 weeks. Dr. Gail Milligan was a GP partner and trainer in Surrey, who also became overwhelmed by her workload as it spiraled out of control. Her working day read just like mine, and in fact, she was working 70 to 80 hours a week. After receiving a complaint, she lost all perspective, and it made like she'd failed everyone. So on July 27th, 2022, Gail took her own life. In a heartbreaking message that had been widely shared on social media by Dr. Milligan's husband, Christopher, he said the unbearable pressure of her job had finally got to her, and he was in no doubt that the job had made her ill. Next slide. Even back in 2019, senior GPs were calling for action to help tackle the endurable workloads in general practice, and were asking for a greater focus on expanding the GP workforce to reduce pressure. The government was warned then that they should be coming good on their promise to recruit 6,000 GPs by 2024, and that was considered a. However, in April 2022, the BMA Rebuild General Practice campaign did a survey that found that almost 1 in 4 GPs knew a colleague who had died by suicide. In September 2022, the BMA revealed that GP calls to its counselling service had more than tripled in the last year compared with pre-pandemic levels, and that they made up 63% of the total calls to the service. A major Pulse magazine survey revealed in June 2022 that half of the existing GP workforce planned to retire at or before the age of 60, with respondents citing reasons such as burnout and workload. Next slide, please. There's been no shortage of disturbing tales from GP practices about the rise in abuse towards staff over the last few years. GPs have been stabbed and they've been hit over the head with baseball bats. In October 2022, armed police were called to my practice in the leafy rural Sussex, where a patient had punched a doctor and hit a nurse. GP practices and their staff are literally being used as punch bags. This abusive and aggressive behaviour is indicative of a wider trend. Data provided to Pulse by the police forces last year showed a rise in crimes involving violence at GP surgery since 2019. This behaviour coincides with a drop in patient satisfaction and problems with access. These issues are likely fueled by the anti-GP rhetoric that comes out of Westminster and which is unfortunately been perpetuated by NHS England. Next slide, please. These charts were taken from a survey conducted by Pulse magazine back in December 2022, which just gives us a snapshot of what practices were experiencing in the UK at that time. Frequently, I have stood in my own phone room of my practice and listened to the phone calls that are being taken by my team. And all too often there have been very abusive, ranting phone calls that have been lasting 5 to 10 minutes where the team just couldn't get a word in edgeways. Often we had episodes where patients and relatives were heard in reception screaming and shouting and banging on the reception desk. Frequently there would be offensive posts on local community Facebook pages about the staff and doctors, a phenomenon well known to MPs, but the majority of GP staff are local to the community that they work in, and they find it very, very difficult to deal with this anger and abuse from the people that live in the same town or village as them. It was these sorts of scenarios which caused the loss of 8 members of staff over a 2-month period at my own practice. Next slide, please. Ooh. We now have nearly 2,000 fewer GPs than we did in 2015. This leads to capacity and access issues, as well as an increase in workload. The workload has increased so much to the extent that general practice is processing nearly 5 million more appointments than in August 2019. However, we have also seen the nature of appointments become more complex. A growing number of patients now need care for multiple or chronic conditions, and many are presenting to GPs with concerns and conditions linked to the cost of living crisis. A large number of appointments are used by patients sitting on secondary care waiting lists whose illnesses are deteriorating while they are waiting. The complexity and the severity of illness that we are now having to manage further increases the risk of burnout. Next slide, please. It is hard to think of a more challenging time in general practice. Too many GPs are now finding their position untenable and feeling too stretched to guarantee patients. The reason for the GP crisis is multifactorial, but it is very much exacerbated by the constant fixation with GP access. Ministers have poured finance into digital telephone systems and provided support staff, but this has not addressed capacity issues. And this has unfortunately also driven patient expectations. Patients should be able to call us and send us an email or walk in to get an appointment, but the GP contract makes it too complicated, and this has in effect worsened the situation. Next slide, please. Without general practice, the NHS won't survive. We see a vast number of the patients that come to the NHS, and we deal with most of what people need from the health service. If we're not there, secondary care services will just be completely overwhelmed. In the last 10 years, 1,000 GP practices have closed, with 66 practices just in the last year. In the last 10 years, 10,000 GPs have retired or left the NHS, and they have not been replaced. Doctors Association UK have been working with the media to raise awareness and help change the rhetoric. We feel the narrative is starting to change and that the media is getting a good grip of the issues. Indeed, The Telegraph recently published a well-balanced and empathetic piece highlighting the GP crisis, which indeed included my own personal story. This is a great example of how we can come together to evoke change. However, if the situation does not change imminently, you will see more GPs hand back their contracts and you will see more GPs retire early or leave for the sunnier climates. We want Westminster to start listening to so that we can work together to make the necessary changes needed to save general practice. Thank you.
Hi, I'm Steve Taylor. I'm a GP in Manchester. I've been a GP for 30 years. And it's been a joy to be a GP. I mean, in some ways, Sarah's painted quite a stark and difficult picture of general practice, and it is getting more and more difficult. In fact, I think over the 30 years, I would say the last 10 years have been the hardest. And as a partner during that time, I can say that with categoric truth. I'm in the latter stages of my career. I'm 58. And then most of that time, I've kept my head down. I've just carried on working as a GP, seeing patients, referring patients, dealing with a practice, running a practice. And it was about 2 or 3 years ago that I came across this graphic, next slide, that actually transformed the way I started to think about what we were doing. And I've put the numbers on here, but it was an image that the King's Fund put out, which shows the number of GP appointments compared with the other appointments that are taking place on an average day in the NHS. So 1.3 million appointments taking place on an average day in the NHS in general practice. And if you compare that with just the little blue bubble above it, which is 67,000 occurring in A&E, I was amazed at the difference given the amount of information we get on the media. And it made me realize that actually for every 20 patients I was seeing, only one was attending A&E. In fact, probably 1 in 30. So something like that. And that was amazing to me. And I didn't really know it. So, and what's even more surprising, next slide, is how little funding actually goes to general practice. So general practice receives about 5.6% of the NHS budget currently, and that's down from about 7%. You can see a little square in the middle there saying primary care, 14.9 billion. The primary care includes other things as well as general practice. So general practice itself just gets 10 billion of that 14.9 billion. And it's an increasing problem, the funding. So next slide. As GP workload has increased, you can see that in the graph from the BMA showing the number of appointments taking place every month that have risen in pre-pandemic levels from about 25 million a month to currently now about 31, 32 million a month. At the same time, general practice funding has decreased. Now, it's gone up from £153 a month to £164, £65 a month. But in real terms, if you compare that with inflation, that's about a 20% cut, because actually £153 in today's money is £200 per patient per year. And this is the reason why actually some practices can't afford to employ GPs. Most of the funding that's been put into general practice has gone into other areas. So next slide. So NHS England has been spending money on other primary care initiatives, acute care hubs. Acute care hubs have a sort of average cost of about £48 an appointment. Pharmacy first appointments, which are meant to reduce 10 million GP or 10 to 20 million GP appointments, actually cost more, approximately £48. I mean, I've spoken to some pharmacists about this, and of course they don't get funding for every appointment they see, but the policy itself was brought in to reduce GP appointments. We've got 30,000 ARS staff, or additional staff, being brought into general practice, and they've brought 40 million extra appointments per year. But if you do the maths on that, for 1.4 billion, that's £35 an appointment. And then urgent care treatment centres actually cost about 85. And if you were to go to A&E, it can cost anything between 100 and 300 pounds. So GPs practices are receiving £165 a year for an all-you-can-eat buffet, and that all-you-can-eat on average is 7 appointments per patient per year, which averages out about £23 an appointment. So it seems a bit weird, doesn't it, that we're spending so much money on other initiatives to improve access to primary care, but we're actually spending less money in general practice, which is one of the reasons why we've got some of the problems. Next slide. So we've got 2,000 fewer GPs than 2015. We've got 1 GP now per 2,300 patients, and that's gone up nearly 300 patients per GP since 2018. And actually what we recognise is that a patient ratio of 1 GP per 1,800 is probably what we need. And that was something we did have in 2015, and it's got worse and worse and worse. So one of the ways that we can address this is by encouraging NHS England to fund practices to employ GPs so that we've got more GPs per patient. And this would improve access to care and continuity, as Lizzie's already mentioned. Next slide, please. So the biggest problem we've got in general practice is not training GPs. 4,000 new GPs will be brought into the practices in August. It's actually that we're not retaining them. And this graph illustrates this perfectly from the Institute of Government, showing that 1 in 4 GPs under the age of 30 are leaving. And there's a worrying trend for the 30 to 39-year-olds also leaving in higher numbers. And we've got to readdress this. And the only way to readdress this is to fund practices to employ doctors, or actually to reassign some of the money that's spent in other areas so that we can employ doctors, because currently ARS funding is only available to PCNs to employ a set number of staff, which don't include GPs. So we at Doctors Association UK are really encouraging the MPs and NHS England to consider how we get GPs to stay in practice. And given that in 2015, Jeremy Hunt said we need 5,000 more GPs, 2019, it was Matt Hancock saying 6,000 more GPs. The fact that over those period of time that we've de-invested in general practice, it's no wonder we don't have those numbers. Thank you.
Good morning, my name's Ellen Welch and I'm a GP up in Cumbria, and today I'm going to be talking about some of the solutions, because believe it or not, there really are some very achievable solutions to the problems that we're currently facing. So I think if you were to ask any GP up and down the country, they'd be able to come up with a long list of micro solutions to the specific problems in their areas. But what I want to focus on today are the bigger solutions which are within your power to implement as a new government, which can make a real difference to UK GPs as a whole. So number 1 is financial investment in general practice. We've already heard from Dr. Taylor that GPs are getting less than 5.6% of the NHS budget. The GP contract today is worth 2 billion less than it was 5 years ago. So we're existing in a system that's been chronically underfunded. We know this. If we were to invest just £35 per person per year, then we could restore GP funding to 2015 levels. So to put this into context, if I was to have 1 takeaway coffee 5 days a week, that would cost me nearly £900. A £35 investment into the NHS, into our health, is extremely achievable. And what's more is that this doesn't need to be new money. A new government can choose to reallocate the money being spent elsewhere within the system. For example, the 2 billion that has been spent on inefficient schemes which fragment care, such as the Pharmacy First scheme, the Additional Roles and Reimbursement Scheme, ARRS, this pot of money can be reallocated and reinvested into core general practice. So that brings us on to number 2, which is using this money to invest in the workforce. I do think it's worth highlighting once again, so it's very clear, the Treasury has ring-fenced this pot of money for staff funding in general practice, which cannot be spent on GPs or practice nurses. I think there was a question in the chat earlier, thank you for that. It was saying, aren't GPs part of the problem? Partners are actively involved in employing ARRS roles over doctors and actively colluding in the erosion of general practice. And I think it's worth pointing out that this money is ring-fenced by the government. GPs can't use it on GP partners can't use it on GPs or practice nurses. And this is what we need to be able to do. I think the additional staff members such as pharmacists, social prescribers, physios, they're all very useful when they're present in addition to GPs. However, we have the shortage of GPs that we've already spoken about, yet we have this unbelievable paradox where GPs are currently out of work. So we need the additional role schemes to be exactly that, and for the investment to be in GPs. How do we do that? We need to enable GPs to stay rooted in their communities by developing meaningful careers for new GPs, by supporting fellowships and educational funds. We need the freedom to use our budgets for the things that work. So we need to aim to increase GP numbers so that we have safer ratios of patients to doctors. This will then enable us to provide what patients care about, which is number 3, continuity of care. So Dr. Tobity spoke about this already. We know that continuity of care reduces hospital admissions, it reduces mortality, and it results in improved patient satisfaction. To be able to do this, we need GPs to be embedded in their communities. The traditional partnership model is best placed to achieve this, although we're finding that most new doctors don't want to be a partner. And this is because of the huge personal risks that are associated with being a partner. The business fails, you can lose your house. Many of the newer fragmented models that have emerged are because of this, because no one wants to be a partner. So one solution to this is to give partnerships limited liability. The partnership model, given the right support, has proven that it can provide the acute and chronic care that patients need. It just needs investment. So then we come on to the 4th and final solution and ask that can be delivered by governments. And this is something which you could all achieve fairly quickly to bring about significant long-term results. And this is to create a cross-party NHS. So in the 20 years I've been a doctor, the NHS has been reorganised multiple times. Each time the government changes, we have a new terminology for what is essentially the same thing. The staff in these freshly branded organisations are the same people with the same ultimate goals, and a lot of time, money and energy is spent reinventing the wheel. So what we need is stability. We need to remove the NHS from short-term decision-making based on party politics and form a cross-party group to make longer-term decisions for the provision of health and social care. Germany does this, and each election, the health service is not part of any manifesto promises. So we need to adopt this in the UK. We need stability in our health service, and we need to be able to change the narrative to implement longer-term plans. Thank you. What I would like to say is that we have a manifesto that we will send out to you all after this presentation. And there's also this book, which is what our talk is based on. And that will tell you a bit more about the problems. And we'll also send you some links so you can see how to get that. So I'm going to pass you back to Lizzie now.
Okay. So that's the end of everything that we we wanted to say this morning, and I think it's fair to say we all could have gone on for hours longer. And just to repeat my invitation from the beginning, that if you do want to discuss with us at any point, you know, please do let us know. We're all more than amenable to a chat on the phone and further discussion. And this is how you